The following podcast is part of a certified educational activity titled Recognition and Management of Axial Spondyloarthritis, Best Practices for Family Medicine Physicians. Access the entire activity and complete the post-test at peerview.com/RBU860. Downloadable slides and practice aids are also available.
Hi, this is Dr. Len Calabrese. I'm a professor of medicine at the Cleveland Clinic Lerner College of Medicine in Cleveland, Ohio. Welcome to this educational activity on axial spondyloarthritis. By way of introduction, we'll be talking about back pain, which is extraordinarily common, affecting 80 to 85% of people at some point in time in their life. And it's one of the leading symptoms that brings patients to primary care. The NHANES survey, which is designed to sort out health problems at a population basis, has demonstrated that in adults aged 20 to 69, the prevalence of chronic low back pain is 13%, and this is very high. One important but under-recognized cause of low back pain is axial spondyloarthritis, which we'll be talking about extensively. This is an inflammatory rheumatic disease that predominantly involves the spine and the sacroiliac joints. This figure really outlines the spectrum of spondyloarthritis, and you can see that there are two large circles, axial spondyloarthritis on the left and peripheral spondyloarthritis on the right. Spondyloarthritis is a term that means inflammatory disease of the spine, and as you can see on the left, we have divided this into two subcircles. The larger group is called non-radiographic axial spondyloarthritis, and it represents exactly what it sounds like, that plain film x-rays are generally non-revealing, and within there is the traditional ankylosing spondylitis, a disease that we've known for a century that causes marked radiographic damage. On the right are a number of conditions that all can have spinal involvement, but have prominent peripheral features such as reactive arthritis and uveitis and nonspecific urethritis and inflammatory bowel disease. So when you think of spondyloarthritis, it is a family of disorders with shared features. Again, the nomenclature is very important because it has evolved. For those that have been to medical school a few years ago, you knew ankylosing spondylitis, this relatively rare and somewhat arcane disease. Now we recognize it as merely a subset of this family. And the term axial spondyloarthritis has been ensconced since 2009. Within the spectrum of spinal disease, as I mentioned before, there is a non-radiographic version where, as I will demonstrate to you, patients are identical with similar disease loads and morbidity and comorbidities, but with a relatively preserved radiographic imaging. The other is the classical ankylosing spondylitis, which we now call radiographic axial spondyloarthritis as opposed to ankylosing spondylitis, and that image will speak for itself. The peripheral SPA terminology, which we won't spend a lot of time on, are those patients who have symptoms that are not predominantly back pain, but they may also have r-axSpA as part of their illness. Now, this image gives you the typical clinical features of axial spondyloarthritis. And patients with either non-radiographic or radiographic axial spondyloarthritis share many common clinical complications. I've mentioned uveitis, anterior uveitis, enthesitis, inflammation of the tendinous insertions into bone. There's over 100 of them anatomically in our body. Peripheral arthritis, psoriasis, a very common immunologically driven skin rash, and inflammatory bowel disease. And then one of the musculoskeletal complications, which is so telling when you see it, is dactylitis, with multiple joints within one digit being swollen and painful, the so-called sausage digit. Regardless of whether there's radiographic or non-radiographic disease, these patients have a similar disease burden. They have back pain, they have fatigability, they have disturbed sleep. This detracts from their personal empowerment and employability. So if we move along and ask the question, if this disease is morbid, what really determines the poor quality of life in patients who have r-axSpA? Well, patients with chronic inflammatory diseases that are characterized by pain often have exacerbations and remissions. And during these periods of exacerbation, there is worse physical function. That pain itself disturbs sleep induces fatigue. All patients, regardless of whether it's psoriasis or r-axSpA or inflammatory bowel disease, have a higher incidence of intercurrent mood disorders. Now, I'll only give you a brief snapshot of the pathogenesis of ankylosing spondylitis, but it's a remarkable story, and it goes back essentially 50 years with the discovery that HLA-B27 is associated with this disease. Prior to these studies done in the early 70s, the genetic associations with diseases were Mendelian. Someone in the family had this and someone else in the family had the same disease. There were very few biomarkers that were associated with hereditability. That all changed with the notion that these human leukocyte antigens, which are involved in the integrated immune response, actually segregated to diseases. And the first tight association was this finding of HLA-B27 and ankylosing spondylitis. This was discovered simultaneously in the United States and the United Kingdom and literally transformed the world of immunogenetics. Yet 50 years later, we still don't understand exactly the mechanism by which HLA-B27 imparts pathogenicity. And there are multiple theories ranging from its role in T-cell mediated cytotoxicity and infection to the theory that this is a fragile HLA molecule which can misfold and generate inflammation. It has been linked to a variety of other pathways, and we'll leave that as a work in progress. Two other prominent fields of immunopathogenic research are the strong association of axial spondyloarthritis with inflammation within the bowel and dysbiosis, in other words, perturbation of the microbiome. This is a very hot area of research, but it is not translated into therapy. And then finally, since all of these diseases share enthesitis, the biology of enthesitis has advanced dramatically. Dennis McGonigal in the United Kingdom has contributed largely to our understanding of this. And, all of us after the age of 50 have these bone spurs noted radiographically, and that is mechanical stress when our tendons, insertions into bone cause traction and the accretion of bone. In spondyloarthritis, this physiologic mechanism is now on fire, and that's why young people can develop this complication. So a few thoughts on pathogenesis. Now, this image of the natural history of axial spondyloarthritis is a brilliant depiction of what we actually see in patients with this spectrum of disorder and actually explains why we have been confused by this disease for so long. This was developed by one of the leading voices in axial spondyloarthritis, Atul Deodar. And let's start out at the upper left. It is a river. And so the analogy is that you start with some type of back pain. And as you can see, the river kind of ambulates down with slowing down, speeding up. There are side tracks and ultimately different tributaries. So if you start with merely pain in the back, some patients will inexorably wind up in the lower right with severe ankylosing spondylitis. We understand that, and we always thought this was a linear projection. Others, on the other hand, will have back pain their entire life, but never fuse their spines or show radiographic abnormalities. And others will have inflammatory back pain, something that we'll talk about extensively, for a while, and then it'll go away, or it will come back. So we have to be poised to make this diagnosis at any point in time in a patient's journey with chronic low back pain. All right, definitions. I've already given you the 30,000-foot view that all these patients fall under the rubric of axial spondyloarthritis. Some have radiographic disease, which is synonymous with ankylosing spondylitis, and others are non-radiographic. So radiographic is easy. Unequivocal evidence of sacroiliitis, and I'll show you pictures of this. The plain films will tell the story in the vast majority of patients. Non-radiographic, on the other hand, a relatively recent disease, a disease for which there are now numerous drugs approved for therapy, far more difficult. No unequivocal radiographic evidence of sacroiliitis on plain films, yet the MRI, a more recent addition to our armamentarium of radiographic assessment, can be highly revealing. On the other hand, the symptoms and burden and quality of life can be equally affected by either types. The emerging concept is that r-axSpA is a single disease continuum, yet some patients just never develop the radiographic findings. So this histogram shows the burden of disease activity in both radiographic r-axSpA, ankylosing spondylitis, and the non-radiographic versions. And while these terms may not be familiar with you, they represent functionality, mobility, quality of life, and pain. And you don't have to be a statistician to see that regardless of whether this is non-radiographic ankylosing spondylitis of less or greater than 5 years duration, these are equally affected domains. Now, again, a half a century ago, this was considered virtually a disease of men. And one of the remarkable advances in our understanding of this disease is that women are well represented with this disease, unfortunately. Yet there are some sex differences. Men tend to have more radiographic r-axSpA, in other words, leading to this fusion of the spine, and women tend to have more non-radiographic r-axSpA. Women have more cervical spine involvement than men do. Women tend to have greater enthesitis and dactylitis and have more widespread pain. There are also different clinical features, including women having poorer quality of life, more intercurrent mood disorders, fatigability, and generalized pain. There's also differences in immunopathogenic signatures with differential expression of key cytokines such as TNF and IL-17. The risk factors associated with progression to AS, the radiographic version, the condition that we fear. We see people still on the street with these bamboo spines that can't bend their chin down to see their feet. Fortunately, something that is diminishing in frequency. But it has been consistently found that if you have radiographic evidence of sacroiliitis early on in your life, you're more likely to go on to develop progressive radiographic changes. If there is rich inflammation by MRI, similarly, that is a poor prognostic marker. And if you have elevated inflammatory markers, in particular the CRP, the prime arbiter of this, these are all associated with radiographic progression. Other findings which have been somewhat inconsistent include presence of HLA-B27, which we'll discuss, certain clinical features such as pain radiating into the buttocks, and smoking, which has been associated with disease progression and also, parenthetically, a risk factor for RA, totally different disease. So with that background, thinking about this in terms of how back pain presents to primary care, how do we make this diagnosis? Well, unfortunately, we don't have a high throughput test of adequate sensitivity and specificity to make this diagnosis, and the gold standard is clinician judgment, taking all the evidence into account. The tools that we have, aside from clinical tools, which are the most important, are acute phase reactions such as CRP. We may use HLA-B27 to increase or decrease the likelihood. We have plain films, and we have MR imaging. Now, this is a complicated slide, but there's a message here on the classification criteria for r-axSpA. Here you have 3 sets of criteria starting from 1961 through 1984, the Rome, New York, and modified New York criteria. The bottom line here is that if you didn't have X-ray changes, you didn't have this disease. Now, by 1984, we're starting to kind of doubt the strength of this, but we didn't have any other type of imaging. Now, by 2009, the ASAS criteria, the society that studies spondyloarthritis, placed far different emphasis on entry criteria of having this chronic low back pain in a young person, and then also did include X-ray findings as one path, but also the presence of B27 and sacroiliitis on MR imaging. And then by this time also included all the features of the peripheral spondyloarthritis that I talked about, psoriasis, uveitis, inflammatory bowel disease, and the like. Now, the probability of axial spondyloarthritis based on clinical features and imaging is kind of an iterative process. If you just say, well, what's the chance of having spondyloarthritis among any patient in the primary care office that has back pain? Well, it's pretty low. Because back pain is very common in the population. If you then up the ante and say, well, tell me something about that back pain, and I'm going to talk to you about inflammatory back pain in a minute, but that has a specific clinical feature to it. It's insidious in onset. It gets better with exercise, worse with rest. That increases the likelihood by threefold. And then if you add to that any of these clinical features, which you can get in a minute by taking a history, does that pain radiate into the buttocks? Has it got better with nonsteroidals? Have you ever had Achilles tendonitis or tennis elbow or uveitis, etc.? Now we're going up another 3 to 5-fold. Add to that HLA-B27, very strong positive predictive value in the right patient. We're at 90%, and then imaging, may secure it one way or the other. This next image shows for patients the inflammatory back pain quiz. This was developed by the Spondyloarthritis International Society, and I love this. And I think that in a primary care office, I would have this available to every single patient that had back pain. And in 5 questions that takes less than a minute, did your back pain start before the age of 45? Did it develop insidiously? You didn't fall off the roof raking leaves when your back pain started, just kind of crept up on you. Does your back pain and stiffness tend to ease with physical activity and exercise? Young people who have this often go out and walk or jog. Does your back pain get better when you rest? Mechanical back pain does. Any of you that have it know that, but this does not. And this 5th question is kind of the bonus question because it has very high specificity. Does it wake you up in the middle of the night and feel better when you get up and move around? So remember that. We'll come back to that, and I'll tell you how important that is in the exam room. Now, if you look at this MR imaging of SI joints, you don't have to know much, but you can see this T2 on the top and T1 fat suppressed image on the bottom, and you see all this white stuff. That shouldn't be there. That is edema along the SI joints where the arrows are, and if you see it in multiple sections on both sides of the joint, this is very strong evidence of sacroiliitis. Adding the spinal image on the right, showing all this bone edema at the corners of the vertebrae, is kind of like icing on the cake, but not necessary. We don't actually do that in our screening imaging. Now, the next image of plain films, this is just an AP pelvis. It's a low-cost screen. But the problem is obvious to people that look at this. It's graded 1 through 4. Now, A, B, C, and D. Now, D, you don't see sacroiliac joints because they're fused, and anybody would notice this, and every radiologist would say this is ankylosing spondylitis. But this grade 1 up here, unless you're a musculoskeletal radiologist, this will be overlooked. And there's just a little bit of pseudo-widening, a little bit of sclerosis, could very well be normal or someone that's had some trauma. And then moving along to grade 2 and grade 3, it becomes progressively more obvious. So the point is that patients with non-radiographic either have normal films or patients with radiographic who have mild imaging, it is missed by non-musculoskeletal radiologists routinely. Now, the next film is a bamboo spine, and you don't really even need to get an x-ray to know that you have this, although there are other things that can lead to extensive calcification. This patient cannot bend over, cannot see their feet, cannot touch their feet. It's significant. The differential diagnosis of axial spondyloarthritis is broad of patients in your office. Mechanical back pain is the most common, usually comes on abruptly. Diffuse idiopathic skeletal hyperostosis, called DISH, usually seen in older men, diabetics. The flowing ligamentous calcification in the spine can be confused with axial spondyloarthritis. Fractures of the vertebral bodies, often far more acute. Degenerative arthritis is the leading differential diagnosis, and this often takes some teasing out to do this. And then rarer causes of back pain, including far more pernicious conditions such as septic arthritis, metastatic disease to the spine, crystal arthritis, and others. Why do we care about axial spondyloarthritis? This is a treatable disease, so you must start with the notion that not all back pain in your office is mechanical, even though that numerically is by far the most common cause to bring a patient to a primary care office. So, inflammatory back pain. I'm a rheumatologist. I've done this for a long time, and I'm actually an immunologist, but I see a lot of general rheumatology still. And if I have a trainee, an intern, or a student particular with me for just a few hours in a clinic, I think, what can I teach them? I'm not going to teach them advanced immunology or inflammatory disease. I say, do you know what inflammatory back pain is? Do you know how powerful a tool this is? And the answer is generally no. So the features of inflammatory back pain are all historical, and they can be gleaned in less than 90 seconds. It is a cardinal symptom of axial SpA, and it occurs in people who are less than 45 years of age and in people that have had back pain for more than 3 months, chronic. The sensitivity of this, depending upon how many criteria you have, is from 70 to 80 or even higher of picking up patients with this disorder. It is not perfect, but it's a very powerful tool. This is a chart that shows inflammatory back pain versus mechanical back pain. So I have a patient in my office, they're less than 45, and they have had back pain for a few months. Some may be earlier than that. And then you ask them, how did this come about? It's not, I just woke up with this one day. I don't know. It just kind of crept up on me. I was in college and I started noticing my back was hurting. I thought it was the mattress in my dorm. What's the best time and the worst time of the day for you with your back pain? A non-leading question. Oh, it's really bad in the morning. How long does it last until it's not going to loosen up anymore? Oh, a half an hour or an hour. Mechanical back pain does not have that and usually gets worse later in the day. What do you do when your back's bothering you? When you hear this young person who found this in college or when they went into the service, he said, I'll go out and jog. And I'll get to the importance of that because it's often very helpful. I already mentioned it's chronic and occurs in younger people. And then the other thing is, what else makes it better? Have you ever tried, ibuprofen or naproxen or any of these other drugs? Oh, yeah, I take it for a few days, it helps, and then, then it'll come back. So all of these things go together. Now, I'll give you 2 bonus questions for your office practice. Where does that pain go from your back? Does it go up or down your spine? And when they tell you that it radiates into their buttocks, and you say, which one? And I say, well, sometimes it's on the left and sometimes it's on the right. That adds great specificity to this. And then my final question is, after you go to sleep, does this back pain ever wake you up at night? And they say, yes, it does sometimes or frequently. What time? Usually the middle of the night, 2, 3 in the morning. And when that happens, I ask them, what do they do? They say, I get up and I walk around the house. When I hear that, there have been studies that show when you affirm to all of these questions I'm asking you, the specificity is far greater than 90%. So moving along, it's more common than we think. This is the iceberg. The patients with ankylosing spondylitis are only on the tip. If we look at the data from N. Haynes, we can see that inflammatory back pain, maybe 1 in 20 people have this. Axial spondyloarthritis is, 1+%. Ankylosing spondylitis is about half of that, or a third of that. And B27 is overrepresented. But remember, this is not a test for r-axSpA. It's an immunogenic marker present on 6% of the general population, 7.5% of Caucasians, and a lower frequency in African Americans and Hispanics. But if we think about HLA-B27 and this disease, it is still a potent tool because people with r-axSpA, particularly radiographic r-axSpA, 90% plus are positive for B27. And In monozygotic twins who carry this, the second twin is likely to have the same disease 60% of the time. That's very high in hereditability. Monozygotic twins with rheumatoid arthritis, where one person has it, the other twin only has about a 20% chance. So genetics are important. The frequency of HLA-B27 across the spectrum of these diseases is highest with r-axSpA and then falls off in reactive arthritis, psoriasis, enteropathic arthritis, and beyond. So it's really the spine that holds all of this together. So r-axSpA may be more common than RA in the United States. And, RA is one of the most common diseases in a rheumatology practice. Yet if you ask any rheumatologist, how much r-axSpA are you seeing? They'll say not nearly as much. That's because these patients are underdiagnosed and unrecognized in the community. And this is not blaming primary care physicians or orthopedists or, health center doctors at colleges and in the military. It has just been underappreciated and hiding from us. And that's what this whole presentation is about. So another reason to care about this is the diagnostic challenges, and we can solve this under recognition by some very easy measures. Let me point out to you that the consequences of this under recognition are quite strong, that the delay in diagnosis is often, 5 to 10 years, and the majority of people today are undiagnosed and not receiving specific care. Some studies show as many as 1 in 4 patients who present to primary care offices with chronic low back pain have some version of r-axSpA. So the reasons for misdiagnoses are outlined in this diagram. And I'll point out 2 of these kind of channeling biases. If a patient has classic inflammatory back pain, there may be a couple features that falsely reassure the practitioner that this is not a serious form of inflammatory rheumatic disease. One is not appreciating the fact that this inflammatory disease gets better with exercise. And in fact, I can tell you as a young trainee, before these criteria were ensconced in our diagnostic armamentarium in rheumatology, I would think, well, geez, this young 20-year-old who has this intermittent back pain, he tells me he can go out and run 2 miles. I said, I can't even run 2 miles at that point in time. And he feels great. So false reassurance. The second false reassurance and channeling to incorrect diagnosis is response to nonsteroidals. When I talk about therapy, some patients get dramatically better with nonsteroidals, and that may deflect them from having an accurate diagnosis. This slide talks about the personal experiences with diagnostic delay, particularly women with non-radiographic r-axSpA who have more cervical, thoracic pain. People say, oh, they're women, they have fibromyalgia, this is not, and they get blown off. People that come in with stories of pain, stiffness, impact on sleep and fatigue, often don't dig deep for the presence of an inflammatory rheumatic disease. Patients have to be their own self-advocates, and I think that instruments such as this spondyloarthritis quiz, when you see the answer to 2 or 3 of these, that means that these patients need more careful evaluation. There have been strategies that have been adopted and studied, and this is a very complex chart, but I'll make the point that merely by using techniques such as screening for inflammatory back pain, that's what the Herman study of 2009, using what we call Kalin criteria, 5 questions that I reviewed with you, can identify a high degree of patients with spondyloarthritis in a practice that is quite remarkable among patients with chronic low back pain. This ranges from 30 to 50%. So think about this. There are easy ways to screen. This possible screening approach is what I like the best. So remember this when we finish this discussion. For all the patients coming into your office that say they've had back pain for greater than 12 weeks, and they're less than 45 years old when these things started, then just go to the left and ask those 5 questions. If they have 3 of the 5 questions that are positive, that's worse in the morning, better with exercise, better with nonsteroidals, gets up in the middle of the night, these patients need a further diagnostic workup. Now, you may be interested in getting an AP pelvis, and the radiologist may pat you on the back and say, I think this is early r-axSpA or ankylosing spondylitis. If at that point in time you don't want to get the x-ray, but you have enough pretest suspicion, send to a rheumatologist. The second pathway is doing the x-ray, but as I told you, if that x-ray is normal, you still need to send them to someone who can dig deep for this diagnosis. And this can get tricky in the borderline cases. The last is using the HLA-B27. As I said, when patients have intermediate pretest probability, this test can be potent in terms of enhancing the positive likelihood of the diagnosis. And in fact, if you have inflammatory back pain with even 2 features in your B27 positive, you're very likely to have this diagnosis. But a negative B27 doesn't take you out of it. So the reductionist view of this, inflammatory back pain in a young person, please, if you have any uncertainty as to the diagnosis, send them to a rheumatologist to do the heavy stepping. So moving along, these patients are important for another reason, is they all carry comorbidities. I've talked to you about the peripheral SpA comorbidities of enthesitis. I'm amazed that when I finally make this diagnosis in a 40-year-old, that they've had lifelong plagued with Achilles tendonitis, infra-knee tendonitis, pes anserinus, enthesitis along the pelvic brim and beyond. Have they ever been to an ophthalmologist for a red eye that they got steroid drops for? That means that they probably had uveitis. They may have even got a course of prednisone. Do they have symptoms of inflammatory bowel disease, or somebody in their family have any of this? They also have extra-articular manifestations, including, in the advanced forms, cardiac involvement, free aortic insufficiency, in the old days, secondary amyloidosis, and fibrotic lung disease, particularly at the apices, and structural complications in the spine. We don't see this very much anymore, and we're very happy because patients are getting better therapy. The most prevalent comorbidities are noted in both r-axSpA and non-r-axSpA. These are not dramatically different graphs here, looking at all of these features of cardiovascular disease and intercurrent mood disorders and beyond. Now let's segue to talking about the latest evidence to personalize the management of this disease. And there are numerous goals, including relieving symptoms, maintaining function, trying to prevent the serious spinal complications of this disease, manage comorbidities, and support them as individuals. So let's start with some general principles. The initial therapy of all of these patients must be non-pharmacologic intervention, and that includes patient education. I use a lot of different tools. I like the patient education from UpToDate. It's easy to download and print for them. They need to know that they have an inflammatory disease, that there are consequences to not treating it. We want them to quit smoking. Do they need psychosocial support? And then finally, all patients need some evaluation by a physical therapist for spinal mobility and posture exercises. The last thing in the world we want to do is see someone at the age of 50 with their head tilted down and can't move it back up. And teaching patients that they, shouldn't sleep on multiple pillows and how to maintain range of motion are important. I have no problem with physical therapy, massotherapy, mind-body therapy, acupuncture, but spinal manipulation that involves any type of high-velocity techniques is to be avoided in these patients. Now, moving along to pharmacologic therapy. This is moving faster than a raging river, and I'm showing you the 2019 ACR, Spondyloarthritis Association, and Spartan, the U.S. group that is involved in spondyloarthritis research, recommendations for patients with both radiographic and non-radiographic r-axSpA. I'll show you a chart that are now approved for non-radiographic as well as radiographic disease and new classes of drugs that have been approved. I will point out to you that step 1, first-line therapy, is something that all of us can engage in with our patients. And so, you can have a strong suspicion that this is spondyloarthritis, and there may be a wait to get into your local rheumatologist, but you can start with physical therapy, psychosocial support, and start them on nonsteroidals, the cornerstone of therapy. While nonsteroidals probably do not have capacity to prevent radiographic damage, they very well may slow it. And they also can give profound improvement in quality of life. Any nonsteroidals are adequate, but they should be used in full doses and a fixed regimen. It's not use it when your back feels bad. It's use it every day. And it takes at least 2 weeks to get a therapeutic response. And to be a nonsteroidal failure, you have to do it for at least a month. And we generally try 2 nonsteroidals. You guys understand the toxicity profile of nonsteroidals as much as we do, as on the rheumatology side. And I will point out that most of these patients are young and they're not very high risk for NSAID gastropathy, but I usually prophylax for that in people on high-dose regular therapy as well. The next slide actually talks about the treatment options beyond nonsteroidals. And as you can see, there are currently 3 classes of targeted therapies that are approved. TNF inhibitors, the cornerstone, which have been around for a long, long time. IL-17 inhibitors, which have been more recently approved. And finally, 2 JAK inhibitors, tofacitinib and upadacitinib, which have been more recently approved. As you can see, certain of these drugs have been approved for non-radiographic axial spondyloarthritis as well as AS, or radiographic spondyloarthritis, and others are approved only for ankylosing spondylitis. I believe that virtually all of these drugs will ultimately be demonstrated to be equally approved. This is a personal C-level opinion on this. The trials to approve for both indications are long and complicated, and we're still very close to the beginning of this. But in terms of regulatory approval and third-party payer approval, you should be aware of this. If you code for non-radiographic axial spondyloarthritis, only some are approved. Now, if you look at this bar gram, which shows the responses in clinical trials for spondyloarthritis based upon all of these classes of drugs, the TNF inhibitors, the IL-17 inhibitors, and the JAK inhibitors, and on the bottom comparing to placebo in gold, and then the blue is the first biologic therapy that they got, and then the reds are people that usually have failed another biologic. And the readout is something called the ASAS-40. It measures disease activity, it measures pain, quality of life, functionality, and mobility in an equation. And as you can see, all of them are quite potent. These ASAS-40s of approaching 50% are rather dramatic compared to what we had with nonsteroidals, which are just down at the end of the graph. This has transformed the treatment of this disease to something that was very discouraging and depressing to the patient and to the practitioner, to something that we are so happy to treat because we can control this disease in the vast majority of people. ASAS-40 is a fairly high bar, so people that don't get this still may be getting meaningful improvement. If you look at the ASAS-40 responses in non-radiographic disease, very high as well. So, we consider non-radiographic and radiographic equally treatment responsive, and that's why we're so eager to these people that have been called mechanical back pain or fibromyalgia to get into the circle of care, get their physical therapy, nonsteroidals, and if they don't respond, started on a biologic. That's why we think that referral for the use of these, more complex medicines are important. So the approach after multiple pharmacologic therapy failures is far more complex, and that is the domain of the rheumatologist. And, we work interprofessionally with primary care, orthopedists, other practitioners who may be entry points for chronic back pain. And the first thing we want to know is diagnosis correct. Are there other complications here? Is there OA in addition to this? Is there another pain condition such as a central sensitization, such as fibromyalgia, or other condition causing sleep disturbances and fatigue? Does the patient have unrealistic expectations? And sometimes it is refractory, and maybe it's just 1 or 2 joints, and sometimes skilled bone and joint radiologists can do strategic injections, but that is a far advanced therapy. What about tapering these medicines? Does that mean that these people are on this for lifelong therapy? Well, it's a complicated question. We don't have a simple answer. The answer is yes and no. People who have had this disease and have suffered and have lower quality of life often are so happy to be controlled on a biologic. They have no interest in stopping this therapy. Others who are risk averse or drug averse, when can I get off of this? When can I get off of this? Well, I'm just summarizing, a handful of trials which basically show that when you stop these therapies, people feel generally good for a few months almost all the time. But over time, a preponderance of patients will reactivate, and they need to be retreated. There are these theoretic risks that have been encountered in practice that once a person has responded dramatically and then flares off therapy, a fear that they will not be able to capture the degree of disease control moving ahead. There's no guarantees about that. I think it is infrequently seen, but something that we worry about, and I mention to people before they want to pull the trigger and stop all their medicines. Closing in on the end here, talking about management of comorbid conditions. Yes, we're partners in this, and patients who've lived with an undiagnosed disease are often facing anxiety and depression, sleep disturbances, and we need to look at all the secondary causes and to support them psychosocially and treat these things when needed. 20% of patients with inflammatory rheumatic diseases have fibromyalgia, and graded exercise, water therapy, all of these things can be very helpful. Mind-body practices. I'm very big into using things such as Tai Chi and Qigong across the spectrum of rheumatic diseases, but this has been shown in randomized controlled trials to be highly effective in fibromyalgia. Have we managed other intercurrent disorders as well? So let me conclude by giving you 3 points to consider. 1, identify chronic low back pain in people younger than 45 years of age, and then quiz them for features of inflammatory back pain. This is a linchpin of starting the process of making this diagnosis. Once that has been achieved, that is grounds enough to refer to a rheumatologist for further evaluation. On the other hand, if you want to start with plain AP pelvis films and look for sacroiliitis, if present, it has positive predictive value, but if it's negative, the diagnostic process still needs to go on. Once diagnosed, initiate the patient on full-dose NSAIDs with all the caveats of safety. In addition, refer these patients to physical therapy immediately for patient education and exercise programs appropriate for patients with axial spondyloarthritis. And then finally, for patients even who have the diagnosis and have been to physical therapy, if they have not responded to nonsteroidals, strong consideration to moving them to biologics via referral to rheumatology. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RBU860. This activity is supported by an educational grant from Novartis Pharmaceuticals Corporation.